Now, second most dreaded problem is recurrent laryngeal nerve injury. It can be complete or partial. It can be because of traction, contusion, crush, diathermy burn, misplaced ligature, compromised blood supply, and it causes vocal cord paresis or paralysis. Now, how do you detect or how do you come to know that the patient has got a vocal cord paralysis? It can be unilateral or bilateral. In unilateral, there is postoperative hoarseness, breathlessness. It is subacute. Vocal cord remains paramedian, creating a normal voice. May not manifest for weeks or days. Atrophy of the paralyzed cord may lead to worsening of the voice. Because it's unilateral and it is paramedian, the other vocal cord compensates and patient may not have symptoms for very long time. That is why it can manifest after weeks after surgery. Now, bilateral nerve injury, bilateral paramedian position, partial airway obstruction, and it needs immediate intubation. Now, biphasic stridor. Stridor is a noise which is heard on inspiration. If both the vocal cords are paralyzed, you have a stridor both on inspiration and expiration, and that is a very classical feature of bilateral nerve injury. Now, what do I do if I suspect a laryngeal vocal cord paralysis? Direct and indirect laryngoscopy. It is mandatory that the patient undergoes a direct or indirect laryngoscopy preoperatively to identify undetected vocal cord issues. And all the more important is immediately after surgery on the table, anesthetist, as she is extubating the patient, should look at the vocal cord and their ability to move. Their position is normal or paramedial or adducted or abducted. All this should be detected by direct laryngoscopy at the time of extubation. Now, laryngoelectromyography can differentiate between vocal cord paralysis and cricoarytenoid joint injury during intubation. It can predict the prognosis. Bilateral nerve injury with airway obstruction need re-intubation or tracheostomy and laryngoscopic confirmation of the paralysis.